Get going in just a few moments. Yeah, what was going on there with you? Like you were climbing out of the sunset there. Wait till 7:01. Give people one last chance to make it. Okay. Mm. Yes, hello. Okay. All right, why don't we get going? I thought I would review today the case that we did on Friday with Dr. Love. So Uzo was involved in the case. So Uzo, you're free from questions today. So this is a 9-year-old who had multiple episodes of SVT, is not pre-excited, 28 kilos, male, had no other medical problems. Okay, so when we start the EP study, or whenever you're looking at an EP tracing, always remember that you first have to look at the legend on the left-hand side in order to understand what each of the channels are. So the first 5 channels, and I should also add that every single laboratory displays the signals slightly differently. And so when you're taking your board examination, for example, it'll be very important for you immediately to first look on the left side in order to understand what the channels are. In our particular laboratory, we have always displayed the His in yellow and coronary sinus in green and the high right atrium in red, but every lab will do it differently. In this case, the RV is in blue and the MAP or the ablation catheter is in white. But almost always, most electrophysiologists will display the surface electrocardiogram at the top of the screen. And as I'm fond of telling people, it's always useful to look at the ECG when trying to understand what's going on the intracardiac, because, of course, the EKG is what we're used to looking at. Of course, we're at 100 paper speed, so it's 4 times as fast as usual, but that's intended to demonstrate the relationships of these intracardiac intervals that are very close to one another in milliseconds. So in this case, we have 4 ECG leads, 1 V1, AVF, V6. We have a distal and proximal ablation catheter. we have the high RA catheter, and then we have 3 HIS pairs, distal to proximal. Some electrophysiologists will display this in reverse, proximal to distal, but it has been our standard to do it this way. And yet here we are displaying the coronary sinus from proximal to distal. And in this particular case, Dr. Love, who is the electrophysiologist, prefers to use an octopolar catheter with 8 pairs. And so some of you who've worked with me know I usually use a decapolar catheter. So there are 4 pairs. This is the proximal pair going out to the distal pair. And then finally, there's a catheter sitting in the right ventricle. This is the RV pass pair. And here's the stimulation. And so in this case, we actually started with rapid atrial pacing, which I'm not displaying here, but the bottom line is we do that. I do that normally because I want to see what the AV node can do before we get started messing around with catheters in the heart. It's a good baseline approach. And in this particular case, this young boy could conduct 1-to-1 up to rates of 200 beats per minute or cycle length 300. At that point, he started to Wenke buff. So the next thing that I usually will do in these cases is I will do what's called extrastimulus testing. This is a common technique, and excuse me if I'm repeating things for those of you who know what this means, but sometimes useful to repeat things, where we pace at a cycle length of 500. And remember that the cycle length is, if you want to convert that to a heart rate, it's 60,000 divided by the cycle length. So in this case, 60,000 divided by 500 would be a rate of 120. And then we put in an extra stimulus or an 8th beat at a certain cycle length. And every time we do it, we drop or decrement the extra stim by 10 milliseconds. So here we are 500 to 450, and we're looking at the A, H, and V. And for time's sake, I'm going to drop it by 20 milliseconds in this display. And here we are, AHV. And we know that the AV node typically decrements. And so we should expect that the A, which is this little signal, and the H, which is this small signal, this interval should lengthen as we get more and more premature on the extra stimulus. Here we are at 390, and we can start seeing that the A to H interval is lengthening ever so slightly. This is also demonstrated here in the PR interval. Compare, for example, this PR interval to this PR interval. So we see that it is longer, consistent with the presence of decremental AV conduction. Here we are another 20 milliseconds down, and the AH interval is a little longer PR. Here we are at 340. 320, and now we're at 300, and we see again that the PR interval is much longer on the extra stim than it is on the drivetrain, and this is also displayed here with a longer AH interval. You also may notice that the interval between the pacing spike and the actual atrial depolarization is also longer if you compare this interval from here to here versus here to here, and that's because as we get more premature, there's also decremental conduction within the atrium itself. All tissues are decremental to some degree. And so as we get more and more premature, the stimulus to A interval will also lengthen. Here we are at 500 to 270. And we see again that the stimulus to A is much longer, and also the A to H interval, markedly longer than in the drivetrain, suggesting that we're going down a decrementally conducting AV node. Here we are at 500 to 50. See a very long AH interval, and also longer decrement between the stimulus to A. And then at 500 to 240, whoops. At 500 to 240, we go A to H, and then something happens. And why don't I ask Grace if she has any idea what's going on here. Grace.
It looks like, so A to H, AV, AV, AV. So the A doesn't conduct after the there are two beats that are not paced that conduct, but then the A doesn't conduct after that.
That's right. So to say that a little more clearly, we have, this is the drivetrain. S1 always refers to the first number. When someone says, 500, 240, they mean S1 is 500, S2 is 240. You can also have an S3 and an S4. In this case, this is single atrial extrastimulus testing. So we're going 500, 240. So we go down the AV node. And then what's happening here, Grace? Let me just show you. This is the last one. This is 500, 250, AV. And this is 500, 240, AH. But then there's something else here. And as you rightly said, there are two beats of what looks like tachycardia. And the question I'm asking, I guess, is what kind of tachycardia is this?
It seems to be coming from it's earliest in the distal coronary, so a left-sided pathway.
That's right. So this is the first evidence in the procedure that the patient has a left-sided accessory pathway, because what's happening is we're going A down the AV node, HV, and then it's re-entering and coming up an accessory pathway. And the reason we know it's coming up an accessory pathway is because the earliest retrograde A is actually located in the distal coronary sinus pair. And you can see that as we go more proximally, they're later. The earliest pair is actually CS distal. This A to V, or V to A interval rather, is fairly short. So we go down the AV node, up the accessory pathway, down the AV node, up the accessory pathway, down the AV node, and then it stops. So where in the tachycardia circuit did tachycardia stop, Grace?
I don't understand that question, Dr. Pest. Could you say that again?
Well, tachycardia has, in this particular case, presumably has two pathways, right? It's going down the AV node and up the accessory pathway, right? So from A to V to the node, the ventricle gets depolarized. It goes back up the accessory pathway. The atrium is depolarized, and so on and so forth. So is it blocking in the AV node, or is it blocking in the accessory pathway?
It looks like in the accessory pathway.
That's right, because we go down the AV node, and then we try to go back up the pathway, and there is no conduction up the pathway. And it's important to remember, when we talk about reentrant tachycardias, we remember that there are three requirements for reentry. There needs to be a unidirectional block in one pathway. In this case, that's simple because this is a retrograde only conducting pathway, or a concealed accessory pathway on the left side. There needs to be an area of slow conduction. There have to be two pathways, which in this case there are, and there has to be an area of slow conduction. So what's happened is that as we've become more premature, we've caused enough slowing in the AV node that we have tachycardia reentry occur. So it's a nice demonstration. So this is so far in the case the only proof we have that there is a left-sided accessory pathway. And then Grace, just to finish this up, so we were at, this was 500, 240, and then this is 500, 230. So what happened here?
It looks like we winky balked.
No.
Oh, sorry. Let me see. A, B, A, B.
So again, this is S1, and then this is S2.
So there's a stem. Oh, and
there's a stem, but is anything happening? Look on the surface electrocardiogram. Remember, that's always a good first place to look.
But there's no conduction.
That's right. There's no conduction, and there's actually no capture either, right? Oops, sorry. So when we pace the atrium, we don't see anything afterwards. We don't even see a P wave. We don't see any electrical activity. So what is this? What refractory period would we say we have achieved here?
Atrial. Sorry, there's.
Yeah, no, that's right.
Yeah, AV. Would you say atrial or AV nodal?
So that's a good question. So this is actually the atrial effective refractory period, meaning that at 500/230, we can no longer capture the atrium.
Okay.
And we can't tell what the AV node refractory period is because if we can't capture the atrium, we can't test the AV node. It's possible that the AV node would conduct faster, but because we can't stimulate the atrium, we
Makes
can't
sense.
test the AV node. So the standard nomenclature at this point would be, we would say that the atrial ERP is 500/230, and the AV node ERP is less than or equal to 500/230. That's how we would formally say it. Because yes, it's possible it could conduct faster, but there's no way to prove that because we are unable to capture the atrium. That makes sense?
Yes, thank you.
Thank you. Okay, now here we're pacing the ventricle at cycle line 500. And what do you think is going on with the pattern of retrograde conduction? Let me ask Neha Alawalia. Neha, what is going on with the retrograde conduction? So we're just straight pacing the right ventricle, right? Typically, the RV catheter is placed in the apex of the right ventricle. That's a standard location to pace.
Mm-hmm.
What is happening in the retrograde conduction?
So looks like almost in all the coronary sinus, it's really hard to say, but they seem to be on time, at the same time, and then you see a deflection after that in the his. So I think this is all retrograde conduction to the pathway.
Okay, so I agree that it is retrograde conduction, but compare this conduction pattern to, wait, let me find it. So this was the tachycardia, right?
Mm-hmm.
So keep that in your mind's eye. Does that look retrograde conduction like that?
Yeah, it looks different.
Right. So again, just to remind everyone, this is what so the earliest retrograde A is in the coronary sinus. It's quite obviously clear earlier in the distal CS than in the proximal CS. And you can even see that in the high right atrium, there's a small atrial deflection here that is even later than any of the coronary sinus. And we've already established that this means that there is conduction through a left-sided accessory pathway. So, but this looks quite different, doesn't it?
It does, yeah.
So what we're seeing here appears to be conduction of the AV node, right? Because the A is probably smushed into the V here. And all of these electrograms they all are either on time with one another, or certainly it doesn't have the pattern where it's clear. I think you would agree that CS distal is not obviously earlier than CS proximal or than the HIS. Do you agree with that?
That's for sure.
And that's quite different, say, than here. Look how late the high right atrium is on these tachycardia beats when we're going up the accessory pathway in comparison to this right ventricular pacing where the high RA is almost on time here. Okay.
Mm-hmm.
So this is actually an interesting observation where in tachycardia we go up the pathway, but with right ventricular pacing we're going up the node. And this is unusual. Normally, when a patient has an accessory pathway on the left side and we pace the right ventricle, we will see what we refer to as eccentric retrograde conduction. This would be considered eccentric conduction, and it's called eccentric because the earliest retrograde A is not near the AV node. Normally, the only way that patients can have VA conduction or ventricle to atrial conduction is via the AV node. And yet, in this case, we clearly see that it is what we call eccentric, meaning it's earliest in the distal coronary sinus.
Did you lose him? I can't hear.
Dr. Pass, are you still there? We can't hear you.
Sorry. Can you all hear me there? Can you hear?
Yes, now we can.
Sorry,
Yes.
I got booted off. I have terrible internet connection, it seems, in my office. Okay, can you see the screen again? Can you see the screen?
Yes, we can.
Okay, great. So, so what is going on here versus here? Why did the pattern is different? Do you agree with that? Neha?
Sorry, I was on mute. Yes.
So that's the AV nodal pattern. Then I give 12 milligrams of adenosine and the pattern changes. So why does the pattern change?
So now we blocked at the AV node, and this is through the pathway. This
That's
conduction is
correct.
through the pathway.
That's right. So this pattern looks an awful lot more like our tachycardia pattern, right?
Right.
So this is demonstrating that, can you please, yeah, thanks. So that's demonstrating that there is a pathway, but that when we pace the right ventricle, we don't see it. And this is actually an interesting observation. We published this a few years ago, and we refer to this as the hidden concealed left-sided accessory pathway. And this was a multi-center study with all the groups in New York City at the time. And this is an image from that paper showing that when we pace the right ventricle, we see that when we look at the coronary sinus, and this is proximal to distal, we see that the pattern looks fairly normal, meaning that when we pace the right ventricle, it looks concentric, meaning earliest in the coronary sinus proximal, and as we move more lateral later. However, when we put the catheter in the LV and pace, we see that the earliest retrograde A is actually in the coronary sinus, distal or second to distal most pair. This is obviously later than this pair. And when we have orthodromic reentry, it looks similar as well, with the earliest retrograde A in the mid-coronary sinus pair. And so this is a unusual form of accessory concealed pathway in that when we pace the right ventricle, we don't actually engage the pathway, and we're going up the AV node. But when we pace, when we give adenosine and block it, we see that we are able to go up the pathway. So the question, of course, is why is that? And we don't really know, but probably the most likely reason is that in a young patient, remember this patient is only 9, retrograde AV node conduction is probably very robust. The pathway is much farther from the pacing catheter tip in the right ventricular apex than it is it's much farther than the AV node. And so we probably, when we're pacing the right ventricle, we go up the AV node because it conducts rapidly and because it is physically closer to the stimulus than the left-sided accessory pathway. In an older child, this is unusual, although not unheard of. So this is, so the only reason we have 2 forms of evidence that there's a left-sided pathway. The first point is that we have 2 beats of tachycardia with atrial electrostimulus testing. And the second is that we have demonstration of an eccentric VA conduction pattern when we give intravenous adenosine. Okay. So now we're doing ventricular extrastimulus testing, which of course is routine. So just like we do the atrial extrastimulus testing, we're going to pace the ventricle at a fixed rate and put in extra stimuli. And so here we are at 500, 400, 500, 390. I'm just going to come down faster for the sake of time. 500, 350. 500, 310. So we're seeing that this pattern is not really changing very much. And just like the AV node decrements antegrade, it also decrements retrograde. And if you look at this VA interval, they're all smushed together, but they are subtly wider apart than they are on the drivetrain. Here we are at 240. And then we paste the V, and Perna, what happens here? So this is 500, 230, pacing the V, S2, and what would we call this, or what is this?
So when you pace it at 230, there is no conduction here. Like I see the P wave, but then there is no conduction of that P wave.
Well, not exactly. This is actually a T wave from the prior QRS. You're right, it looks like we're paced, but remember, this is ventricular pacing, not atrial pacing, okay?
Oh, yeah, right.
And so here we are, V pacing, we capture the V, we have VA conduction, then I put in a V pacing spike, and what happens on the surface electrocardiogram?
It does not capture this pacing when you pace.
Correct. That's correct. Right. So what will we call this then?
So this is the ventricular,
Right.
refractory period.
That's right. This is the ventricular effective refractory period, or sometimes we call it the VERP. So again, this pacing maneuver, which should have demonstrated nice eccentric retrograde conduction, does not. So now you have an accessory pathway. We know it's on the left side. So we know we have to go to the left side. So Dr. Love did a transeptal puncture. But how are we going to map this? So the pathway so far, we have only been able to demonstrate in tachycardia or with adenosine. And we can't give adenosine 63 times during this procedure so that we can, demonstrate the eccentric conduction. So how would you propose that we are going to demonstrate this conduction? I will go to a non-Mount Sinai fellow, Anas, who has been kind enough to come to all of these. Are you there? Okay, maybe they're in thought only. I see someone named Christina Fink. Are you on the line? Let me see here. Anas says he curiously has no microphone. Okay, well then we're going to go back to Perna. Sorry, Perna. So how are we going to demonstrate this pathway to map it? How would we normally map a left-sided pathway? So we put the catheter on the left side, but it is concealed, meaning it only conducts retrograde. And another term for this type of pathway, an old-fashioned one, but a very descriptive one, is a so-called unidirectional retrograde accessory pathway, or a URAP. That's a term they used to use a lot in Boston. So how would you show the pathway in order to map it?
So you pace it, and then the closest A to H interval would be where it would.
Well, what you mean is the closest VA interval is where you.
Sorry, yeah, will retrograde. So V to A interval, the one which will conduct earliest, would be indicative of the pathway.
That's right. But the problem in this particular case is that when we pace the right ventricle, we don't actually demonstrate the pathway, right? Because this is the pattern that we're seeing when we pace the ventricle, which is this non-eccentric pathway. And so one of the things that we learned in that paper was that the most consistent, so there are two ways to really map this, right? One would be to induce tachycardia and map in tachycardia, right? Because in tachycardia, you go down the AV node and then up the accessory pathway. And so you could map the VA interval in tachycardia. But when patients are in tachycardia, the heart is beating very rapidly, and it can be difficult to maintain good catheter stability at that point. And so a lot of electrophysiologists would rather not ablate in tachycardia. Also, when you ablate the pathway, tachycardia will terminate and the catheter can move, although there are pacing maneuvers to avoid that. But you could do that atrial extrastim and just map on the extra beats, the 1 or 2 tachycardia beats, but that would require doing extrastimulus for every single one. So what we did was we placed a catheter after Dr. Love did his transeptal. We gently advanced the catheter into the left ventricle, and lo and behold, what we see is that the pattern is eccentric, suggesting that the earliest retrograde A is in the distal coronary sinus, right? This pattern is very different, right, than this pattern, where when we were pacing, the V and the A were essentially on top of one another. Here, when we're pacing the left ventricle, we see that the earliest retrograde A is clearly in the distal CS, just like in tachycardia. And as we move farther from the distal CS, the ventriculoatrial time lengthens, okay? Whoops. So this is an example of, now why is it eccentric? Because we're probably pacing much closer to the pathway physically, and therefore we are engaging the pathway before we engage the AV node. And so Dr. Love, based on this, he perked the artery and he placed a quadrupolar catheter gently across the aortic valve into the left ventricle. And we were able to pace the ventricle at a slow rate, or 100, 120 beats per minute, and map the accessory pathway. Because this therefore demonstrated retrograde conduction via the accessory pathway, whereas right ventricular pacing would not do that. So that's an interesting little wrinkle in this case. And then,
I'll ask later.
Go ahead, Neha, go ahead.
I was just saying, has this been the experience with all concealed hidden, or this was just special, different?
So most concealed pathways, you can conduct up the pathway by pacing the right ventricle. In other words, usually the pattern will look like the pattern that I'm demonstrating on the screen right now when pacing the right ventricle. So actually, demonstration of pathway conduction on the left side of the heart is usually very easy from right ventricular apical pacing. This is an unusual pathway in that it could only be engaged in either tachycardia or with left ventricular pacing. So the unusual or the difficult part was understanding that the best way to demonstrate it would be to actually place a catheter in the LV and pace the LV. Okay, so on the one hand, we never like to put another catheter in. We don't like to access the artery if we don't have to. It's unusual in an ablation. But in this case, it was very helpful because by knowing this and placing the catheter in, we could map in a hemodynamically stable fashion, pacing only at 100 or 120 beats per minute, versus having to map in tachycardia, which was in this particular strange, that's why we call it a hidden concealed pathway. Because a concealed pathway, remember, only means that it conducts from ventricle to atrium, but not from atrium to ventricle. And it is called concealed because when we look on the surface electrocardiogram, there's no evidence that there's an accessory pathway. So it's hidden by the fact that it doesn't have antegrade conduction. And that's as opposed to, say, Wolff-Parkinson-White syndrome, where the pathway can conduct antegrade and retrograde. And therefore, it is not hidden to us. We know from the surface electrocardiogram that the patient has a pathway because they're pre-excited. When a pathway can only conduct from V to A, but not from A to V, we call it concealed. What makes this more hidden or more concealed is that when we pace the right ventricle, we don't see eccentric VA conduction. We only see it in tachycardia or with LV pacing. And this is an unusual subset of tachycardia or accessory pathway, which is why the little paper that we wrote got published, because it's not very common that this is seen. So my one contribution to this case, where I was not holding the catheter, was to suggest to Dr. Love to place a catheter in the LV, which he did, which made mapping very straightforward. So here we are, and we are pacing the LV, and we see that there is this very nice pattern that is eccentric with the earliest retrograde A in the CS distal. But then the pattern changes during mapping. I'll show it to you here on a paper. It's the exact same tracings, just on black and white. So we see here that in the CS distal, the VA interval is tight here in CS distal, and you see clearly that this A is earlier than that A, or that A, or that A. So this is true eccentric conduction demonstrated with LV pacing. But then something happens at this point. And what that was a catheter bump. So while Dr. Love was mapping, getting very nice signals, you can see the V and the A are very close to one another on the distal ablation. The catheter just touched the area ever so gently, and we have a lengthening in the VA interval. This happens to all electrophysiologists. If this hasn't happened to you, you haven't done enough ablations. But one of the lovely things about use of 3D electroanatomical mapping is that we can actually identify exactly when the signal changed from this to this. Because notice now the VA pathway is earliest in the proximal coronary sinus versus the latest, right? You see this pattern. Look how long the VA interval is here now versus here where it's the earliest, right? Now this A is earlier than this A is earlier than that A, and so on and so forth. So clearly we have inadvertently injured the accessory pathway by the catheter just gently touching it, causing conduction block in the accessory pathway. Now, in the old days, before we used 3D mapping, we would basically just on fluoroscopy say, well, it looked like it happened about here or there, and we would burn at that location, and then we would burn a little to the left and a little to the right, and we would cross our fingers and hope that we had actually ablated the location where the pathway went away. But using CARTO or ESI, you can actually find the exact point, because it's recording all of the signals continuously, as well as recording where the ablation catheter was at the exact moment that anything occurred in the case. So we were able on CARTO to identify this signal going to this signal, and we could see exactly where the ablation catheter was. And in fact, it was immediately next to where Dr. Love had the catheter. So he really had not moved virtually at all. And so we went on with RF current at this location, and the pathway actually what happened was that the pathway came back, and then Dr. Love went on with RF current at this location, and it immediately lengthened, the VA interval lengthened, consistent with a successful acute ablation. And typically after an ablation, as you know, we will test for a minimum of 20 minutes. In this case, we tested for 30 minutes. We saw no further conduction through the accessory pathway through both LV pacing as well as attempts at induction of tachycardia from ATRIAL extrastimulus testing, and the catheters were pulled and the procedure concluded. So this is a very nice example of an unusual form of a left-sided accessory pathway. So this on the left-hand side of the screen is a very typical so-called eccentric pattern of a left-sided accessory pathway. What we see in the first 2 beats or 3 beats, you would potentially need to be able to identify in the board examination as evidence for a left-sided accessory pathway. Over here, we see the difference. In this case, it was from catheter bump, but it could also be from ablation. The delivery of radiofrequency current could also cause this to happen. In fact, that's the most common thing. So anyway, I thought I would just share the case with you, since Uzo was the only person who had the opportunity to see it last week. Okay, and then here is after we give adenosine, and you see here we're V-pacing and there is ventriculoatrial dissociation showing. Remember that before, when we gave adenosine, we saw a demonstration of the eccentric VA conduction when we block the AV node. We give adenosine following accessory pathway ablation because accessory pathways are not adenosine sensitive in general, and AV nodes are. And so if you block the AV node, pathway is also gone because of the ablation, you should see ventriculoatrial dissociation, which is in fact what we see here in this example. So it's a nice example of a successful ablation of an unusual form of a left-sided concealed accessory pathway. Okay, why don't we go to the one fellow that I've been unable to ask a question of because she was in the case, which is Uzo Obiaka. What is the course of the AV node in patients with AV canal defects, and what are the typical features of the ECG in this disorder?
Hi, Dr. Pass.
Hello, Uzo.
I'm going to answer the second question first and then see if we can walk our way back to the first.
That's fair.
So usually patients with AV canal defects have a more left, they have this left axis deviation. And
Axis, right?
I'm sorry?
Usually a leftward and superior axis.
Yeah, leftward and superior axis. And I know this is due to some I don't want to say rotation, but orientation of the AV node because of the AV canal defect. So
Yes,
I'm not
that's
sure what.
true.
I know you want me to say the exact course of the AV node. I just know there's a change in the orientation of the AV node, and that's why.
This is a question that is definitely something that the board people seem to like. And so, as you said, there's usually a superiorly oriented QRS frontal plane axis with what they refer to as a counterclockwise depolarization pattern, which is notable for the little Q waves in leads 1 and L. Okay, and the AV node is displaced inferiorly, with the VSD and the bundle branches also being at the lower border of the VSD. So you have to remember that. Okay, that's unusual because usually VSDs, they're on the top portion of the defect, but in canal defects, they're on the bottom. And again, the ECG reflects a leftward and superior QRS axis as the ventricles are depolarized from a right inferior position to a left superior position. Okay, and first degree AV block is common due to intraatrial conduction delays that are seen in AV canal patients. So this is just something, unfortunately, you're going to need to remember. But, you know, it kind of makes sense, right? That if the conduction is at the lower border of the defect, that it would be ultimately pointing superiorly and leftward. So I would try to keep that in mind. See, there's a question in the chat box here. Also, the left anterior bundle is hypoplastic, is what Rika Arnon is saying, and that is certainly true. Thank you, Rika. That would be another reason that there would be a leftward superior QRS axis in patients with an AV canal defect. And this is a very important EKG pattern. And sometimes when patients have when patients have Down syndrome, which of course is associated with the development of AV canals, we often, like if they have a secundum ASD, we'll often look at the EKG in order to see if there's any possibility that this was an AV canal at some point, or if they have a membranous VSD, which of course is very common in Down syndrome, separate from AV canals. We always are looking at the EKG when the echo suggests something other than an AV canal type defect. We look at the EKG to try and give us some hint as to whether or not there was evidence for an AV canal anatomically in some manner, but oftentimes is not the case. But in this would be a very classic ECG of someone with an AV canal. And again, we want to see a leftward leftward superior QRS axis. And again, remember that the AV node travels along the inferior border of the defect. So I think we'll stop right now. Thank you for joining this week. This has been fun. I hope the EP case wasn't too boring with intracardiac, but I think the more you look at these types of tracings, the more obvious they become. And as I've said from the beginning, in regards to your board examination in particular, the EP questions, particularly the intracardiac ones, generally are very straightforward. And they really often are just asking the questions. You have a clue what you're looking at. And that's important because a lot of the other questions that are asked on the boards are more sophisticated. So we're going to keep pounding every week or other week a little bit of intracardiac EP because these are not difficult tracings to understand if you have some sense of what we're looking at already. I noticed Grace was able to identify a left-sided pathway. That's wonderful. First-year fellow, soon to be second year. And so you're already quite ahead of the game. So thank you for coming, and I will see everybody next week when we start up again. Thank you. Bye-bye.